Good evening, all. On behalf of Indian Society of Hematology and Blood Transfusion, I welcome all the delegates for today's 25th Masterclass lecture on approach the patient with huge splenomegaly. And without wasting no further time, I would like to invite the teacher and faculty for today's masterclass, Dr. Rahul Naithani, Director and Head, Hematology and Bone Marrow Transplant, Paras Hospitals, Gurugram. Over to you, sir.
Thank you. Good evening, everyone. So today we are going to discuss about how to approach a patient with massive splenomegaly. Splenomegaly is a very common finding. We all understand spleen is a vital organ, at least in the early ages, and it reacts to a lot of things. There's hardly any MBBS student who would not have seen a patient with a splenomegaly. So today we are going to understand what spleen is, what it does, how it does, and how do we approach a patient with a massive splenomegaly. And we'll also come to what defines a massive splenomegaly. So first of all, we'll talk about a little bit about the physiology of spleen. So spleen is a reticuloendothelial organ. It basically, in its embryonic phase, it arrives at dorsal mesogastrium at 5th week's gestation. It arises in a series of hallux which migrates towards the left upper quadrant, which is the final position in an adult. This is attached to the stomach via gastrorenal ligament, and the spleen is attached to the kidney via a linorenal ligament. Now, when these small hallux fail to unify to form a single tissue mass, accessory spleens can come up. And this has ramification while we are treating, let us say, a patient with ITP and we do a splenectomy, and we can see a recurrence of ITP because of the accessory spleen being present. Now, these accessory spleens are present in about 20% of patients. The sizes may be variable. Spleen is part of a portal circulation. And we do not know why spleen should be in portal circulation. However, it is presumed that because of the lower blood pressures in the portal system, it allows less rapid flow through the spleen. It minimizes the damage to the normal erythrocytes. Blood flows into the spleen at a rate of 150 ml per minute through the splenic artery. Now, this is a schema of the spleen. Now, this is colored red, but this is actually the white pulp and this is the red pulp. Spleen is broadly divided into two components, the white pulp and the red pulp. This is the central artery, and along the artery, there's a primary follicular area. Then there is a secondary follicular area. Surrounding these areas, there is a marginal zone around the follicles, and then there is a T cell rich zone which sheets the arterioles. Then there is a red pulp area. Red pulp area basically contains of these purple colored pulps, sinuses, and these yellowish looking pulp cords. These pulp cords are actually dead ends. So once the blood goes there, the cells cannot come out. In case cells have to come out, this is the inset of that. They can only sequester through the small sinuses that they have. So only the fully functional, fresh RBCs can, squeeze through these sinuses and come back into the circulation. The deformed, old, or damaged, defective cells will not be able to traverse, and that's how spleen does it. The culling and pitting effects. The red pulp is the site of blood filtration, and it accounts for 3/4 of the splenic volume. The sinusites are lined by reticuloendothelial macrophages. Sinusites are tortuous. Their diameter is very small. So these are very small. These are tortuous. The diameter is very small. The cells actually have to navigate through it. The rate of blood flow through these is very slow. It allows more time for the macrophages to phagocytose the foreign substances such as bacteria, parasite, etc., as well as RBCs that have become damaged or are less able to deform or what have been opsonized by the antibodies. The antibody-coated platelets and WBCs are also removed from the circulation through this. Red pulp contains aggregates of B and T lymphocytes. And in situations where you have, the immune hyperplasia in autoimmune disorders like autoimmune hemolytic anemia, the spleen can become enlarged due to the expansion of these red pulp. Also, the vascular engorgement due to hepatic diseases, the backflows, the cirrhosis, and portal hypertension, that can also cause congestive splenic engorgement and enlargement. So, what are the functions of the spleen? So, in terms of the immune function, basically spleen processes foreign antigens. It makes bacteria and fungi more susceptible to phagocytosis. It certainly does the filter functions where the macrophages capture the cellular and non-cellular material from blood and plasma, including bacteria. Culling effect is very important. Removal of the effect basically means the inefficient cells. the old degenerated senescent platelets and red blood cells. The pitting, the removal of inclusions from the RBCs and returning repaired cells into the circulation. And that's how sometimes in peripheral blood, we show pitted RBCs. Pooling, spleen is a major resource. 30 to 40% of platelets are sequestered within the spleen, and a large number of neutrophil pool is also available within the spleen. And this is the reason that we see post-splenectomy thrombocytosis or leukocytosis in these patients. Iron reutilization, removal of iron from ingested degraded hemoglobin during the red cell culling, and then return the iron to the plasma. So broadly, quality control of the red blood cells, the immune functions, the filter functions, and iron reutilization. Now, any of the exaggeration of these normal physiological functions can lead to splenomegaly. So this is important to understand the physiology so that once we have a patient with splenomegaly, we can tailor our investigations or approach accordingly. Now, how do we approach a patient with splenomegaly? And before I talk about patient with splenomegaly, what actually constitutes splenomegaly? So if we compare palpation, percussion with ultrasound, we see that the sensitivity of palpation is 56 to 71% in different studies, and percussion is 59 to 82%. But again, if 100 patients had splenomegaly with ultrasound, palpation and percussion are going to miss a lot. And also the reproducibility amongst examiner is not very good for percussion. So both the techniques are less reliable in obese patients or patients who have just eaten. So to say if you really suspect splenomegaly, physical examination at best is imprecise. Of course, larger spleens you are able to palpate with much. Also, the spleen needs to significantly enlarge in size. So it is said spleen needs to be more than double the size before we can say that someone has a splenomegaly, because spleen tends to first enlarge, posteriorly, and once that space is full, then only it comes out anteriorly below the rib. So if we talk about the spleen size, what is a normal spleen size? So if you look at the bone marrow transplant healthy donors between 18 to 55, 1230 patients, and the median spleen length was about 11 centimeter. The median volume was about 160. A normal spleen rarely weighs more than 250 grams. However, the size of spleen, increases with height and weight, and the size of spleen decreases with age. So the upper limits for tallest females and males are about 12.3 and 14.5 centimeters. The majority of the radiology centers across world take upper limit of 12 centimeter. So somebody with 12.3 or 14.5 centimeter will be labeled as splenomegaly in the report. However, this will, inadvertently classify 6% of female and 26% of males as having splenomegaly, while that spleen may be normal for their age and weight and height actually. Now, spleen which is palpable is a major physical sign, and it is generally a sign that somebody may be having a disease. Once we have taken into account the normal 6% females and about 20% males could have a radiological splenomegaly. Now, splenomegaly may be a part of the primary disease. Splenomegaly may also be a reaction to the primary. So if we were to, in older times in Hodgkin's lymphoma, splenectomies were done for staging, and only 1/3 of patients had Hodgkin's lymphoma. 2/3 of the splenomegaly were reactive in these. So splenomegaly may not necessarily mean the primary site of illness. Now, if you talk about palpable spleen, in 3% of 2,200 asymptomatic males, fresh college students, 3% patients had splenomegaly, which was asymptomatic. In 3 years follow-up, at least 30% of these students continued to have palpable spleen. And a 10-year follow-up of these asymptomatic patients said that there is no evolution into a lymphoid malignancy. So just having a spleen enlargement may not necessarily be a sign of an illness. Now, how do we grade splenomegaly? Clinically, we say mild splenomegaly if spleen is up to 4 centimeter. We say moderate splenomegaly if it is 4 to 8 centimeter. Massive splenomegaly has traditionally been defined as spleen which is palpable 8 centimeters below the left costal margin, or if its drainage weight is about 1000 grams. You remember the normal weight was about 160, and normal spleen rarely weighs more than 250 grams. So massive splenomegaly is graded when it's about 1 kilogram and above. When a patient clinically has a massive splenomegaly, then which is the topic for today, the differential diagnosis is actually far more narrower. Mild splenomegaly, moderate splenomegaly, there are several causes. Now, what are the causes of splenomegaly? If you remember from the previous slide, the functions of the spleen and any of the exaggerated function could lead to splenomegaly. So the common causes of splenomegaly, and here I'm not talking about massive splenomegaly at this point of time, just splenomegaly. So infections, cellular proliferation, congestive splenomegaly, because of some infiltration, or some infarction and injury. These are the 5 common subsets and the heads under which the cause of splenomegaly would fall into. So if I have to talk about the reticuloendothelial system, remember the spleen is a reticuloendothelial organ. And if there is a reticuloendothelial system hyperplasia, either because of hereditary spherocytosis, early sickle cell anemia, hereditary ovalocytosis, thalassemia major, other hemoglobinopathies, paroxysmal nocturnal hemoglobinuria, especially the hemolytic variant, and pernicious anemia, these patients can have splenomegaly. If I talk about immune hyperplasia as a mechanism, which is generally response to an infection, which could be a bacterial, fungal, viral, or parasitic. Infectious mononucleosis is one of the very common causes of splenomegaly. AIDS, hepatitis, CMV, subacute bacterial endocarditis, septicemia, syphilis, splenic abscess, tuberculosis, histoplasmosis, very common cause in India, malaria, Kala Azar, and then in Western world, trypanosomiasis and ehrlichiosis. If you talk about disorder immune regulation, so hemophagocytic lymphocytosis, you can have arthritis. Feltis syndrome, you understand, is a triad of neutropenia, splenomegaly, and arthritis. Collagen vascular diseases, serum sickness, immune hemolytic anemia is a very common cause of splenomegaly. Immune thrombocytopenia is generally not the primary but secondary immune thrombocytopenia, and immune neutropenia is generally seen more in children. Of course, you could have drug reactions which could cause splenomegaly, sarcoidosis, thyrotoxicosis. You could have angioimmunoblastic lymphadenopathy. Now, splenomegaly also happens in a situation of an extramedullary hematopoiesis where bone marrow is not functional. So, myelofibrosis, we all would have seen children with thalassemia major coming with huge splenomegalys. And then, of course, you can have a marrow damage because of toxins, radiation, strontium, marrow infiltration by tumor, leukemia, Gaucher's disease, amyloidosis. And here the spleen has an extramedullary hematopoiesis. Spleen is basically trying to make more blood because bone marrow is not able to make. If we talk about this abnormal splenic flow, so cirrhosis is a common cause, hepatic vein obstruction, portal vein obstruction, cavernous transformation of the portal vein, splenic vein obstruction, splenic artery aneurysms, abroad hepatic cystosomiasis, congestive cardiac failure, echinococcus, and portal hypertension. So these are the conditions which would lead to congestive splenomegaly. And again, it's important to know so that when we talk about approach to splenomegaly, we look at these histories carefully and then tailor our approach accordingly. When we talk about the infiltrative disorders, so you can have an amyloid, Gaucher's, Niemann-Pick, Stengius, majority of the pediatric metabolic disorders, the Hurler syndrome, hyperlipidemia, majority of them will come in infancy, early infancy actually. Then benign and malignant cellular infiltrations, we all understand leukemia, lymphoma, Hodgkin's lymphomas, they cause splenomegaly. Then polycythemia vera, essential thrombocytosis, myelofibrosis, which is again a myeloproliferative disorder, comes with a splenomegaly. Patients could have angiosarcomas, metastatic tumors, eosinophilic granuloma. Now, the malignant causes of splenomegaly, if you look at the entire Indian community and splenomegaly, malignancy is going to be a very small component amongst the overall causes of splenomegaly. Then one could have, of course, a hemangioma, splenic cyst. There are some unknown etiologies, and frankly, no one can enumerate the causes of splenomegaly. I think each and every one of you will have a patient with a entity which is not listed in this, and this patient would have presented with splenomegaly, which may have resolved over a 6 to 12 weeks time. So iron deficiency anemia, especially in children, 15% can have splenomegaly. Severe vitamin B12 deficiency sometimes comes with splenomegaly. And then, of course, there can be an idiopathic splenomegaly. Now we'll come to our topic, which was for today, massive splenomegaly. So as we remember, the massive splenomegaly is defined as spleen which is more than 8 centimeters below the costal margin or weighs more than 1 kg. The 10 textbook causes of massive splenomegaly are chronic myeloid leukemia, lymphomas, hairy cell leukemia, myelofibrosis, polycythemia vera. So if you see, majority of them are all malignancy side. Chronic lymphocytic leukemia, then there could be Gaucher's disease, sarcoidosis, especially the multisystemic sarcoid, diffuse splenic hemangiomatosis, and autoimmune hemolytic anemia. Now, all these conditions will not necessarily present with massive splenomegaly. They can present with no spleen of 1 centimeter, 5 centimeter, or 10 centimeter. However, amongst patients presenting with massive splenomegaly, these 10 are the common textbook differentials. Now, majority of you will wonder that, you would have seen massive splenomegaly apart from this fairly commonly in your clinical practice. And that's correct. That is also because, in a lot of diseases, the spleen were not supposed to be this large, but because of the natural history, diagnosis not made or treatment not made, many patients with other conditions do present in our clinics with massive splenomegaly. So in India, it's common to see patients with Kala-Azar, tropical splenomegaly, thalassemia major who have not been, adequately transfused, patients with disseminated tuberculosis, and chronic liver disease with portal hypertension. They do come with massive splenomegaly. Apart from that, there will be several other anecdotes with, massive splenomegaly coming in our picture. And like we say, tuberculosis could cause anything except pregnancy. Similarly, we should not discount HIV, and sometimes HIV can come with a large spleen. Now, how do we, what is it that we should ask the patient in terms of history? Again, remember the functions of the spleen, whether the reticuloendothelial hyperplasia, whether it's an immune mechanism, whether it is a congestive mechanism. So what are the symptoms of splenomegaly? Generally, spleen will give you a dragging sensation. So most of the times it's not actually pain, it's a heavy dragging sensation in the left upper quadrant, or just, patient feels that there was a hard feeling on my left upper quadrant. A larger spleen, because it impinges on the stomach, can cause early satiety. Now, vascular occlusion because of any cause, sometimes myeloproliferation, sometimes obstructive disorders, and fairly commonly seen in children and younger ages, it can cause infarction, and once spleen is infarcted, it can cause significant pain. Rupture of the spleen, either from trauma or infiltration, that breaks the capsule, can cause intraperitoneal bleeding, shock, and death. Again, one of the rare presentations, but the audience who is more aligned towards the surgical side would have seen a lot of traumatic splenomegaly. Now, can symptoms point toward a diagnosis? Yes. So if somebody is also complaining of fatigue, this patient may be having a low hemoglobin. If somebody is coming with fever along with splenomegaly, so again, splenomegaly with anemia can have a different set of differentials. Fever with splenomegaly can have a different set of differentials. Here we are looking at infections, malignancies, SLEs, or other similar autoimmune disorder. Patients with bony pain. Bony pain is a very important marker of marrow infiltration, and this could be because of the leukemia. Similarly, there may be infiltration, stretching of actually the splenic capsule, which would be causing a splenic infarct. Then patients with portal hypertension can present with hematemesis. Also, patients with severe thrombocytopenia, either primary or secondary, may come with hematemesis. So these are the pointers these are the historical findings where one could think of whether we are looking at a underlying diagnosis. Of course, personal history of alcohol intake for somebody presenting with chronic liver disease, family history of Gaucher's disease is useful, and residential history is very important. The patient with Kala-Azar is endemic in certain areas. Chronic malaria is endemic in a lot of areas in India. So that residence information also helps us. Now, what do we look at examination? So again, like we had fever with splenomegaly, anemia with splenomegaly, in clinical examination, we can see that patients have pallor. Patients can have lymph node enlargement. Again, the commonest cause for lymph node enlargement are not going to be malignancy, but infectious mononucleosis, tuberculosis, and other causes. However, lymphoma and leukemia should be kept in mind. A size of splenomegaly is very important. As we said, enteric fever will come with, tipped palpable, maybe a little bit of more of splenomegaly. However, massive splenomegaly, the differential diagnosis is significantly narrow. Does this patient has a hemolytic facies? So we all know patients with thalassemia major with hemolytic facies can cause. In pediatrics, there's also other entity where the child would look like exactly thalassemia, it's just that the HPLC is normal. This entity is called CDA, or congenital dyserythropoietic anemia. Again, there's an extramedullary hematopoiesis happening because marrow has dyserythropoiesis, spleen is enlarged. These children typically look like a thalassemia child, but a bone marrow is diagnostic in these. Of course, you look at the signs of uveitis, which could be there in sarcoidosis, SLE. Conventional teaching in sarcoidosis, you will examine the shins for nodes there, and then ascites will be a finding of cirrhosis, SLEs, lymphomas, and one should also look for signs of chronic liver failure like ascites, spider nevi, etc. Lab assessment, once we have looked at the size of splenomegaly and kind of made a differential diagnosis for this patient, the lab assessment is rather straightforward. I think the two single most important tests for this is a complete hemogram and ultrasound abdomen. Rest all investigations are tailored as per your history and examination. Suppose this was an alcoholic, you are looking for more of a chronic liver disease kind of side, you are going to test there. If you're thinking of Kala-Azar, your testing is going on that direction. If you're thinking of chronic malaria, or if complete hemogram is saying leukemia, lymphoma, or such finding, then you are headed there. But the two basic investigations are ultrasound abdomen and complete hemogram. Now, when we are looking at imaging of the abdomen, we should realize that ultrasound is a very good modality for measuring the size of the spleen. However, if there is a situation where I'll come to one of the cases where we need to look at the anatomy or the structure of the spleen, then CT and MRI are superior to ultrasound. But in common clinical practices, ultrasound abdomen is a good enough finding. Now, when we look at the lab assessment, the hemoglobin and the RBC counts may be decreased in a patient with splenomegaly, where they have thalassemia major syndrome, they have SLEs, they have cirrhosis with portal hypertension. The RBC count may be high in cases of polycythemia vera. The TLC or the granulocytes may be low in Feltes syndrome, congestive splenomegaly because of hypersplenism and all, and leukemia. However, the TLC and granulocyte may be increased in cases of infection. Inflammatory disorders, very important sign. You have a patient with fever, splenomegaly, pain, platelets high, you look at autoimmune, platelets low, probably on the leukemia or lymphoma part. Myeloproliferative disorders would come with high TLC, high platelet, high hemoglobin, and a splenomegaly. Now, similarly, platelet count may be reduced if there's an enhanced sequestration, spleen is very big, hypersplenism, destruction of platelet, congestive splenomegaly, and immune thrombocytopenia. Now, immune thrombocytopenia, primary ITP generally does not have splenomegaly. It is the secondary immune thrombocytopenia because of SLE, CLL, or some infection where you may have a splenomegaly. Now, platelet count will be high in cases of myeloproliferative disorder. So once you have a spleen size, you have an adequate history, and you have a CBC, much of the path for the splenomegaly, at least for the massive splenomegaly, is set. Now, the CBCs may reveal cytopenia on 2 or 3 cell lines, which is called hypersplenism, which is basically a splenomegaly, cytopenias, normal or hyperplastic bone marrow, and generally this responds to splenectomy. Now, increased reticulocyte production index is generally less because once the spleen is bigger, it is eating away the reticulocytes also. So the reticulocyte rise may not be that appropriate. Now, we have understood what to take in history, what to look for, in clinical examination. And once we have zeroed into the, the differential diagnosis, then I'll just share some clinical cases of massive splenomegaly because that was the topic assigned. And listen carefully. So this is a 56-year-old male who presents with 4 months history of recurrent fevers. He had pallor, he had abdominal distension, and generally in a lot of our situations, abdominal distension basically means hepatosplenomegaly. This patient had received multiple blood and platelet transfusions outside. When we examined this patient, he had multiple enlarged lymph nodes. He had massive hepatosplenomegaly. Now, for somebody coming with this history and multiple transfusions, lymph node, I would actually also think of a leukemia or lymphoma. However, the spleen was very big. We know once spleen is, beyond umbilicus, with lymph node, fever, 4-month history, multiple transfusion requirement, you're probably looking at a primary, marrow or reticuloendothelial disorder kind of thing. We do the CBC, and this is the finding. And I'll just spend some time here, at least for the students. I see a lot of students have logged in for today's session. So in this report, you see the hemoglobin is low, platelets are very low, and I do not see white blood cell count anywhere. Whenever you do not see WBC, total count, always look at the differential, and you see something called corrected TLC. The moment you see corrected TLC, this patient for sure has NRBCs because TLC has been corrected for NRBCs. So in this patient, the TLC is 19.4. You have 40 nucleated red blood cells. You have myelocytes, you have metamyelocytes. Whenever you have myelocyte and metamyelocytes in the CBC differential, this is called a left shift. Whenever you have a nucleated red blood cell, it is called the left shift of the erythroid series. Whenever you have both left series in the erythroid and myeloid, this is called a leukoerythroblastic blood picture. Leukoerythroblastic blood picture is an absolute indication to do a bone marrow unless the patient has a severe vitamin B12 deficiency, because this could present like that. So if B12 levels are normal, absolute indication to do a bone marrow. And once you do bone marrow, you see that the bone marrow is, fibrous. This patient has a primary myelofibrosis. That explains his low-grade fever. That explains his hepatomegaly, splenomegaly, and lymph node, because they are all sites of extramedullary hematopoiesis. That also explains massive splenomegaly and multiple blood and platelet transfusion requirement. So again, once you have a large spleen size and once you have looked at the CBC, you kind of, have a direction where you are headed. Now, this is an 18-year-old male who presents with a short febrile illness, 2 weeks, weakness, received 2 units of blood transfusions outside, has generalized lymph node enlargement. How do we define generalized lymph node enlargement? Whenever a patient has lymph node enlargement at 3 anatomical sites, it's called generalized lymph node enlargement. So this patient has cervical, axillary, inguinal lymph node enlargement. Spleen was palpable 9 centimeters below the costal margin. Again, short febrile illness, large spleen, lymph node, requiring a blood transfusion. Most likely we are dealing with a primary reticuloendothelial marrow disorder kind of thing. CBC is an important finding. And so this is a young male, 18 years, So again, hemoglobin is low, TLC is very high. We are looking at some myeloproliferation. Platelets are very low, but differential diagnosis in itself gives me a diagnosis. This child has 94% blast. So here we are dealing with a case of pre-B acute lymphoblastic leukemia, which was the final diagnosis. I have taken away all the details because the idea was, the approach towards splenomegaly. This is another patient. This is about 60 years, probably male. She had fever in March 23. CBC showed pancytopenia at that point of time. A CT abdomen was done outside, which showed ascites, peritoneal thickening. Spleen was 22 centimeter. And endoscopic ultrasound guided FNAC was done from the abdominal node, which showed lymphoid proliferation. AFP was positive. This patient was started on ATT. He had a significant clinical improvement. The fever improved, patient felt better, gained a lot of weight post-treatment. Ascites reduced to minimal now, which was massive at that point of time. However, his cytopenias were persisting. And this is when he presented to us in June itself. And when we did his CBC, again, so, the spleen was 22 centimeter. So massive splenomegaly was 8 centimeter below the costal margin, which is the clinical splenomegaly. However, you add 8 to radiological 12 centimeters. So 20 centimeter and above is kind of massive splenomegaly. So this patient is presenting with massive splenomegaly. Again, as we said, in India, tuberculosis is a common cause of massive splenomegaly. So our differential diagnosis was very narrow. However, here the TLC was 13.5 at this point of time. The cytopenia part, the TLC had started to go up. This patient is still pancytopenic because absolute neutrophil count is very low. Neutrophil were only 5%. CBC showed 80% atypical cells. Reticulocyte count was 1.8. The patient also had folate deficiency. Then other parameters were more or less normal. His direct Coombs test, serum protein lactophoresis, viral markers because of AG dissociation they were done. They were negative. So we have a patient with massive splenomegaly who had definite tuberculosis, but post-treatment, a portion of his health improved, a portion of his health continued to be same. At this point of time, a primary lymphoreticular malignancy was suspected because of atypical cells. A PET CT was done also to see the response to previous tuberculosis. And we saw that the mediastinal node has significantly reduced. The much of the CT findings were reduced. However, we saw new lesions in liver. We saw increased MAR activity, and spleen in PET CT was 23.5 with a standardized uptake value of 6.5. Basically, an active spleen. So we did a bone marrow for this patient. This patient was presented to us last week only. And in bone marrow, again, these are the cytopenias. These were the peripheral blood. The imprint smears were paucicellular, scattered abnormal lymphoid cells, large nuclei, finely clumped chromatin, abundant cytoplasm with hair-like projections. And whenever we are looking at a massive splenomegaly, hair-like projection, if you remember the 10 classical textbook differential, we are possibly looking at a diagnosis of a hairy cell leukemia, or sometimes a splenic lymphoma or SLVL, splenic lymphoma with villous lymphocytes can also come. However, morphologically, a smart pathologist would be able to differentiate between a villous lymphocyte versus a hairy projection. Of course, all these still will remain a morphology diagnosis. Finally, we do a flow cytometry to confirm. And once we did a flow cytometry, this patient was turned out to be hairy cell leukemia. So in all likelihood, patient had hairy cell leukemia and tuberculosis both to begin with. AFP was positive, tuberculosis was treated, his health improved, weight gained, ascites reduced. However, hairy cell leukemia persisted. So again, massive splenomegaly, a CBC can give you a lot of clue. So I'm not talking about splenomegaly with CBC. I'm talking about massive splenomegaly with a CBC and someone who is looking at smear carefully. Now this is a 72-year-old male. He presented with a weight loss of 10 kgs over last 2 years, weakness, reduced appetite, and this weight loss and weakness has been increasing over a recent time. His spleen was clinically 9 centimeter below costal margin. We do a complete blood count and we see a hemoglobin is 10, platelets are normal. However, the total white cell count is 365,000. Majority of these cells were lymphocytes. The routine chemistries were kind of normal with some creatinine derangement. LDH was normal. This is the CBC of this patient. I'm not sure if this is projecting clear. In my screen, it's blurred. I'll just read it out for you. So the hemoglobin for this 72-year-old gentleman is 10.1. TLC is 365. Neutrophils are 3%, but absolute neutrophil count is normal. So this is not neutropenic. However, they were 93% lymphocytes. So majority of the cells are lymphocytes and the peripheral smear showed smudge cells. And whenever PS is showing smudge cell, we are looking at a diagnosis of a chronic lymphocytic leukemia. Again, in today's time, at least in advanced center, it is uncommon to see patients with CLL with such a large splenomegaly. Majority of the routine health check, they will present lymphocytosis at dry stage 0 with lymphocytosis alone. However, this was a patient who was neglected. Again, the usual excuses, COVID, did not go to hospital, and then had a splenomegaly anemia. So presented with, Binet stage C or rise stage 3 with deletion 13q. This, I think, a lot of you would have seen in your clinical practice. This is a fairly common illness in our country. So 39-year-old male presents with weight loss and abdominal fullness. Again, we see such situation in advanced centers much less commonly. It is more common scenario in probably peripheral centers or government hospitals or anywhere where a patient is not able to reach a hematologist in a timely manner, where delays because of financial, social, economic, or lack of facility. The patient had a spleen which was enlarged 10 centimeter below costal margin. There's a young patient, so no comorbidities. This was the CBC, and I'll read out the original CBC. The hemoglobin was 11.9, platelets are normal 345. The TLC was 1,96,000. Now remember, the previous patient was 72 with TLC of 3,65,000. However, their predominant cells were lymphocytes. Here in this TLC, majority of cells are neutrophils, 64%. However, what I'm seeing is basophilia, eosinophilia, myelocytes, metamyelocytes, 2% blood. This is a classical left shift, and with basophilia and splenomegaly, my first differential diagnosis here is a chronic myeloproliferative disorder, in all likelihood, chronic myeloid leukemia. And frankly, this is a comparative where you can see from January to February, majority of things have kind of normalized. These abnormal cells. This patient has been obviously treated during this time. So we did a BCR-ABL and it was a 90%, so-called risk was high, basically chronic myeloid leukemia in chronic phase. So again, massive splenomegaly, less commonly seen in advanced centers these days, but again, a classical textbook case of massive splenomegaly. This probably we should actually see less common, because a lot of physicians, pediatricians, and hematologists are very tuned to managing anemia. This was sad. This patient was actually flown from Kolkata to our center. Anyway, this was a 25-year-old lady. She had a short febrile illness, fever of 2 days, dark colored urine for 1 day, was sick, hemoglobin was 2.4, TLC platelets were normal. She received 2 units of blood. She was admitted in ICU. Their creatinine was 2.1. A G6PD was done, checked in a female patient, which was low. The patient was actually labeled as a G6PD deficiency. And after this blood transfusion, when patient was a bit stable, patient was flown to Delhi for further management. On clinical examination, pale, spleen was 8 centimeter below costal margin. So we know, can this be G6PD deficiency? No. One female patient, now rarely female may have G6PD deficiency. However, splenomegaly is there. Splenomegaly rules out G6PD deficiency. G6PD deficiency is an intravascular hemolysis. And this is, splenomegaly is a feature of an extravascular hemolysis. So G6PD is actually clinically ruled out. Her hemoglobin was 5.1, MC was 122. Of course, we are looking at splenomegaly, short febrile illness, rapid drop in hemoglobin, dark colored urine. We are looking at extravascular hemolysis, and probably it was overwhelmed, so now spilled into the intravascular. Reticulocyte count was 60%. So of course, G6PD is kind of out. We do a peripheral smear which shows spherocytosis. A direct Coombs test is 4+. She was diagnosed as autoimmune hemolytic anemia. Her workup also showed an underlying SLE. So this was an SLE which presented like autoimmune hemolytic anemia, and she responded to prednisolone, a CR, in 4 weeks. Now again, remember in AIHA, and I'll talk about our data of AIHA also. So the textbook causes of massive splenomegaly, again, we are talking about massive splenomegaly. These are the common conditions that we encounter in our clinical practices. This was our very old publication from 2006 of autoimmune hemolytic anemia in adults. And I just wanted to, kind of point towards the splenomegaly. Generally, the average spleen size in primary autoimmune hemolytic anemia was 4. And in secondary, the spleen size is actually smaller, 0.5 centimeter. However, the ranges were up to 18 centimeter, ranges were up to 16 centimeter. So, and more than 5 centimeters clinical below costal margin. 11 patient had in primary AIHA and 6 patient here had in secondary AIHA. So massive splenomegaly does present in India with autoimmune hemolytic anemia. This is a case taken from internet. This is not my real life case. But however, this is a situation where, the patient is largely asymptomatic and splenomegaly was picked up, either because CBC showed some anemia, thrombocytopenia, or some portal hypertension, or routine health check, an ultrasound was done and somebody showed splenomegaly. So if you did an ultrasound, there was solid hyperechoic mass has complex echogenic mass with cystic areas, and of course, a large spleen here. When you do CT, non-contrast is isohypodense, and if you do contrast, is homogeneous enhancement. This is not my real life case. The previous cases were real. So this is taken from internet just to understand. This patient actually has a splenic hemangiomatosis. Now, splenic hemangiomatosis can be multiple diffuse hemangiomas across the body with spleen, or just isolated splenic hemangiomas. Large majority of them are asymptomatic and may not need any intervention. However, if an intervention is required, then splenectomy is the treatment of choice. Now, whenever we are talking about splenomegaly, we should always be cognizant of something called hypersplenism. And anybody in India, any physician, any medical practitioner in India understands splenomegaly and understands hypersplenism. Now, hypersplenism is basically a clinical conglomerate of a splenomegaly, cytopenias, a normal cellular bone marrow, and it responds to splenectomy. It's fairly common with patients, even if the splenomegaly is because of hairy cell leukemia or myelofibrosis or chronic liver disease. Beyond the point, that large spleen, which was actually supposed to make more blood, also acts as a double agent and kinds of does the sequestration or hypersplenism. Tropical splenomegaly, again, fairly common in India, is an endemic country for malaria. This is basically an exaggerated immune response to repeated malarial infection. People present with massive splenomegaly, they generally have high IgM levels, and about 40%, 50% patients will have a reduction in spleen size over a 6 months period to this. So again, history is important, clinical examination is important, the clinical background on which this is being taken is very important. Now, how do we treat splenomegaly? It is very simple. Treat the primary cause. If somebody had enteric fever, treat enteric fever. Somebody had malaria, treat malaria. So when we talk about massive splenomegaly, as we read the 10 common causes, chronic myeloid leukemia, in today's time, it's a curative condition. People have normal life as any other patient, any other person without CML. So imatinib, dasatinib, nilotinib, bosutinib, whatever one may want to offer. Chronic lymphocytic leukemia, depending upon the genetics, you treat with chemoimmunotherapies, BTK inhibitors, and ibrutinib, acalabrutinib, or BCL2 inhibitors, venetoclax. Hairy cell leukemia, cladribine still remains, the treatment of choice. Lymphomas, depending upon whether the DLBCL, follicular lymphoma, or a Hodgkin's lymphoma, you treat with chemotherapy as per the type of lymphoma. And mind you, all of these are potentially treatable. So one does not actually need to treat the splenomegaly, you treat the primary cause. Again, if you have a tuberculosis, malaria, Kala-Azar, you do the specific therapy, infectious mononucleosis, and similar other illnesses. Hemangiomatosis, if required, you do splenectomy. Myelofibrosis, we give Jakavi or ruxolitinib, or in younger patient or high-risk myelofibrosis, you do an allogenic bone marrow transplant. If somebody has polycythemia vera, routine phlebotomies, aspirin, and cytoreduction when indicated. Splenomegaly generally will not go away with phlebotomy. This is where you will have to add hydroxyurea to reduce the spleen size. Sarcoidosis, again, depending upon the which system is affected, you do that, and then steroids. Autoimmune hemolytic anemia, you treat with steroids, rituximab, splenectomy, depending upon the patient's requirement. Gaucher's disease, if someone is able to afford this therapy, or sometimes for this orphan drug, this enzyme therapy is available at some centers, then you basically use an enzyme replacement therapy. So once you have treated the underlying condition, usually splenomegaly will regress unless the splenomegaly had been there for a very long time and it is already fibrous where it cannot regress beyond a point. The case in point is myelofibrosis. Now, in case I have treated the primary condition and splenomegaly is still persisting and bothering me, how is spleen going to bother me? Early satiety, compression, risk of trauma, splenic rupture with trauma, football player or road traffic accident. These are the common thing. Or spleen can bother me with hypersplenism. So my hemoglobin may be low, I may have neutropenia, I may have thrombocytopenia. So if I have to take care of the spleen part, the simplest, cleanest thing is splenectomy. You can do open, you can do lap splenectomy. Nowadays, robotic splenectomies are being done. One can do total splenectomy, one can do partial splenectomy in some situations. Of course, there may be situations where patient is not fit, and the liver teams, the liver transplant teams, they are not very keen on splenectomy. They generally try to do a splenic artery embolization in patients with Budd-Chiari syndrome, where post liver transplant the splenomegaly is still persisting. One can do a splenic artery embolization, and rarely patient may be unfit for both splenectomy and splenic artery embolization. This we in hematology practice sometimes do, probably once in 2 to 3 years. We do a splenic radiation in patients, basically to reduce the transfusion requirements. So patients with myelofibrosis and best supportive care, or any such illness where because of spleen their transfusion requirement is higher, we do splenic radiation there. About 5 to 10 grays, radiation, and it actually helps. It basically the hypersplenism kind of relapses about 10 to 18 months later, but in palliative setting that is a good enough time. But I'm not suggesting to do artery embolization or radiation. Primarily it is splenectomy if spleen needs to be taken care of. If spleen cannot be taken care of by primary treatment, then we do splenectomy or splenic artery embolization or splenic radiation. Now, when we talk about splenectomy, before I finish up, we should remember that splenectomy is a definitive treatment for hereditary spherocytosis. This can be the primary treatment for splenic lymphoma or the splenic marginal zone lymphoma. And sometimes when you have splenic lymphoma and bone marrow, metastasis, you just do the splenectomy and the marrow disease, over a period of time disappears. You don't need to treat this patient with chemotherapy. This thing is called, abscopal trick, that once you have hit the root, the secondary changes which were happening kind of regress. This can also be splenectomy is also secondary treatment in hairy cell leukemia, myelofibrosis, pro-lymphocytic leukemia to reduce the transfusion requirement, or once the spleens are fibrosed beyond a point. If you look at the surgical data, and of course these are the older data, they may not be relevant in today's time, but if you look at the indications for splenectomy, they were 10% diagnostic, and many of them actually had a splenic lymphoma. It was therapeutic in 44%, where the diagnosis is already established. In older times, staging for Hodgkin's lymphoma in 20%, and incidental to another procedure. Sometimes somebody present with road traffic accident. Sometimes in a lot of liver surgeries, Whipple procedures, they need to take the spleen out. Now, the only contraindication to splenectomy is the presence of marrow failure, where the enlarged spleen may be the only source of hematopoietic tissue. We make an exception to this exception is myelofibrosis, where spleen was the only site which was supposed to make marrow. But once spleen, increases beyond the size, then it also causes hypersplenism. So the amount of blood it was making, it is going to eat away far more than that. And this is where splenectomy or splenic embolization or splenic radiation may be useful. But by and large, if it's an source of blood formation, generally that's a relative contraindication for splenectomy. And I think this is probably the last slide. The post-splenectomy effects. Now we need to be cognizant that we all read about post-splenectomy sepsis and all that. Majority of post-splenectomy sepsis and mortality data is decades old, 2 decades, 3 decades old, where splenectomies were done in very young children also. And we know that till 5 years of a spleen has a significant, role in evolution of immune system. Till the age of 16 years, that role, reduces significantly. And after 16 years, a spleen does not remain a major role. If we are doing a splenectomy in adults, generally the post-splenectomy issues are not that much. So we need to, kind of delineate ourselves from our conventional textbook teaching that post-splenectomy infection sepsis are very bad things. Much of the data is old in adults, and nowadays it is rare for someone to do splenectomy in less than 5 years of age. However, so in all incomers, the absence of spleen has minimal long-term effects. In the immediate post-splenectomy period, one can have leukocytosis, thrombocytes. You remember the spleen pools the 30 to 40% of platelet and similar amount of granulocytes. However, once splenectomy is done, within 2 to 3 weeks, the counts kinds of regress. Sometimes this can take up to 6 weeks to 12 weeks. In our clinical practice, whenever we have seen post-splenectomy patients, by 2 weeks, majority of these patients have kind of normalized their numbers. Chronic manifestations of splenectomy, then spleen was doing a lot of nuclear pitting and since this is not there, now spleen is not there. So you can see in peripheral smear anisopoikilocytosis, Howell-Jolly bodies, which are basically nuclear remnant. You can see Haynes bodies, which are basically the denatured hemoglobin. You can see basophilic stippling and occasional anabaptise. Once you have a history of splenectomy, you don't need to react to these findings. So pathologist would report this in peripheral smear. We don't need to react. However, someone who has an intact spleen and this finding is reported, then we should investigate this patient that the spleen is structurally there, functionally is not there. So it's basically a functional asplenia or hyposplenia, and we should investigate these patients for that. The splenectomy traditional risk increased susceptibility to bacterial infection, and that is why you need to give pneumococcal vaccine, meningococcal vaccines to these patients, H influenza B vaccine. Patients less than 20 years of age, actually less than 16 years of age, are particularly susceptible. Overall actuarial risk was 7% in 10 years. Again, majority of these patients were less than 5 years of age. When these less than 5 years of age got infection, then the case fatality rate was very high. Frankly, in our early days of clinical practice, anybody with splenectomy, we used to write in, in the discharge summary, this patient has splenectomy. If he reports to emergency with fever, admit him even if he looks fine. Nowadays, we are not doing that. In fact, a lot of our surgeon colleagues who do splenectomies for, the traumas and other things, they do not vaccinate, they do not give penicillin prophylaxis. We being in hematology segment, we do give vaccines. Now, once you give vaccine, you remember spleen is required to make that effect, to generate good immunogenicity, you need an intact spleen. So it's a good idea to vaccinate at least 2 weeks, preferably 6 weeks, but at least 2 weeks before a planned splenectomy. Once somebody is coming with trauma and all, then you don't have an option, then you give vaccine whenever it's available. Again, no hard and fast rules, but in our clinical practice, I'm not saying this is right, this is ideal, or this is wrong. This is what is our center's practice. Post splenectomy, we give oral penicillin prophylaxis for 2 years to all patients. And we should also realize that no increased risk of viral infection. So post splenectomy is basically a capsulated organism risk, no viral infections. So with this quote that one should never argue with a fool, because a fool will bring you down to his own level, and then he has enough experience at that level and he will beat you with his experience. Thank you.